Dr. Baldwin, over to you.
Hi, everyone. Thanks for joining and participating. This is an opportunity for us, since Sonoma County has more than our fair share of disasters, to go over the thought process and training for our field operations guide. So how we're going to, if you're called to participate in our shelter medical service duties. And Dr. Maddox Gonzalez is going to go through how it's not just shelter, the medical, but there's a lot of other aspects, and making sure that people who have been evacuated, who need resources and who need help, are really being assisted, and what our part and role in that is going to be. And also, we're really trying to revamp our DOC, Departmental Operational Center, and making sure that we've got some depth and who's being called to help out with our responses, so it's not always the same people. And we're really trying to make a lot of good strides in our public health preparedness for disasters. So this is I think it's going to be a good training. We're welcoming feedback, questions, so that and we'll try to respond as best we can, and so that we can make this as practical and as useful as possible. So Dr. Mary Maddox Gonzalez is going to, she's been key in putting this field operations guide together, and she's been working with DHS, that includes behavioral health, public health, environmental health, on this, as well as outside county partners like DEM, Department of Emergency Management, and Human Services Department, all of our partners that are called to help out and support the shelters and organize everything. She's going to be presenting today. And then we've also got Andrea Dos Santos, who is our public health preparedness section chief. I think that's the section chief, and the COVID section manager chief as well. Cynthia Timonio is also on. She's another member of our public health preparedness team, and we can hopefully answer questions if you've got some at the end. So Dr. Gonzalez, Maddox Gonzalez, if you want to take it away.
Great. Thank you very much, Dr. Baldwin. Well, welcome everybody to this training, and really appreciate all of the work, the tremendous work that Dr. Baldwin, Andrea, Cynthia, the whole public health preparedness team has done in really taking all of our experience that we've had since the Tubbs fire, and looking together with our county partners at how we can best serve our community members, particularly those members who are evacuated during a disaster. So I'm going to go over the document that we have developed that really synthesizes this plan, and hopefully clarifies what your role would be in this plan. And we really look forward to your questions. So I'm going to share my screen right now. And here we go. You go this PowerPoint to go over the guide and some additional issues. So, as Dr. Baldwin was saying, this is really about sharing this final draft of the Field Operations Guide for Health Services. But I'm also going to talk a little bit about the historical context, how we got to this point, and also the context of disaster response, incident command structure, that sort of thing. Then talk about the plan for integrated health services of those 4 areas that were mentioned: behavioral health, medical, public health, and environmental health services, and the model that we have developed for providing particularly the medical services. You'll notice that animal care and control is not part of this. Their animal care and control has a separate plan, and they really did an extraordinary job during the last year's 2020 fires. And again, they also had a lot of experience with the very important issue of taking care of animals during fires. People often will not evacuate without their pets. It's really a safety issue. And also, these are very traumatic events, and making sure that your pets are okay is a very important part of people's mental health and feeling better in the midst of tremendous stress. I do also want to mention along those lines that many of you were directly affected by the multiple wildfires and were involved in the response, and we're working with a lot of people who were affected by them. So recognize that those of us who have been in Sonoma County, there's a fair amount of trauma associated with this, and second, because of our own experiences, and secondary trauma as a result of helping other people during this time. So this may trigger for some people, reminding us of the fires. And I just admire everybody's tremendous contribution to our community's health and well-being during these trying times, but also recognize that it also affects us. But really, your role is very, very important. And we will be discussing the role of the DHS DOC as well as the DHS employees. And just as Dr. Baldwin said, we really want to leave plenty of time for your questions and for any discussion of the document. So how did we get here? 2017 Tubbs fire really shifted things for all of us in Sonoma County. The rapid onset of that fire really overwhelming our resources at the time. I always think of it as it went beyond our imagination for how bad things could get and how quickly that could happen. And there was really heroic effort on the part of all of you, of all of our community members, our community health partners to address that. But we realized that we could do better, in responding. We could find a more coordinated way of doing it because there wasn't a clear plan that everybody knew what the plan was. And so people did their best as they could in the circumstances. But we really saw a lot of opportunities for learning and improvement in that process. And we have over the course of the multiple fires up to 2020. So in 2020, the big game changer, of course, was the pandemic. So the complexity of responding to a disaster, and particularly sheltering individuals and ensuring that you have staff to support individuals in that sheltering and all the other responses, was really challenged. Many of the volunteers we have in the past depended upon for particularly medical care were in high-risk groups for COVID, could not participate in it. We really saw that we needed a different model, particularly for medical care. And during that time, the county contracted with DEMA, Disaster Emergency Medical Assistance. And that ended up being a model that really helped to bring greater coordination to the provision of medical services within shelters and across medical shelters. And then we implemented some other things, daily shelter health partner meetings. We were working much more closely with at the EOC level, Dr. Baldwin in the role of DHS, of the EOC Ops section health lead, together with EMS section. Frequently that was James Salvante, and working literally, they started working across the desk from the care and shelter branch of sections, the ops section. And that coordination was tremendously important and really helped. So we've learned a lot, and then we're going to talk about some of those learnings. And then, we'll talk more about this, how facing a new reality in terms of the frequency and the dimensions of disasters has required that our model evolve into this new model we're going to discuss. So we remember these scenes in Sonoma County, the fires, the extent of them, the evolution, the uncertainty, issues of air quality, all these things, and associate with that the evacuations, and I will go back to very stressful, traumatic events for members of our community. This is just back from the Kincaid fire, with enormous areas of our community evacuated. And so, we think of the challenges of the floods that would happen periodically at Russian River. This is just a completely different situation, much greater dimensions, not to minimize what the flood is. The floods are tremendous also, but this is really requires more, even additional disaster preparedness and planning. So one of the things that evolved and that was implemented this last year were temporary evacuation points, TEPs. You'll hear them, TEPs, TEPs, there are different terms used, but these are basically locations. They can be identified by the EOC, or the police department, law enforcement can set these up. And it's a temporary, as it says, it's a place to temporarily evacuate to when a disaster occurs. Many of us who've been evacuated multiple times know that feeling of 2 a.m. in the morning and you're in that long line of cars trying to evacuate from where you are and saying, where am I going to go? Well, this is the idea, is that this gives you a place to go to. It provides a site while the shelters are being set up. It also very importantly provides an opportunity where we can screen and triage evacuees, because we want to make sure that people are placed in the appropriate setting. First of all, we want to make sure people don't have COVID, who have COVID or maybe incubating COVID, go to congregate shelters. We want to make sure that somebody who needs a sniff level setting gets to that appropriate setting. So there's both COVID-19 screening and triage, and then medical acuity screening and triage can happen at these temporary evacuation points. Now, City of Santa Rosa has one out in a place for play, and the county also has 2 temporary evacuation points. And I apologize if there's a dog barking in the background. He will stop. Very importantly, all the evacuation shelters that have we have had so many evacuation shelters activated during recent disasters. Both we have the county shelters, we have city shelters, Red Cross shelters, and then pop-up shelters also. That these are the shelters that churches or other groups may set up. They have particularly focused on individuals either because they're a member of a congregation, or it could be a any religious organization that might want to set one up, or sometimes set up because some members of our community are distrustful of going to a government shelter because of immigration status. We really are trying to address these issues of trust among community members. It's so key at any time, but particularly during disasters. So multiple evacuation shelters. And then we look at being used. This is a major part of this, that from 2015 to 2020, look at the multiple fires. This is just every single year fires. And unfortunately, these years are likely to continue on. Because of climate change, we anticipate in our area, throughout California, throughout much of the United States, we will be confronting these large wildfires. In addition to our risks of earthquakes, very important in our area, and flooding and other types of disaster. So this really takes us into a different reality with it. We need a more robust system. So in a disaster, this is just to remind everybody what everybody's role is in disasters. We are Sonoma County, we correspond to that, the confines of Sonoma County correspond to our emergency operational area, and the Department of Emergency Management will be in charge, and that's just done through the Emergency Operations Center, the EOC. Overall responsibility for coordinating and supporting an emergency operation, directing an incident. And within the EOC, the EOC Operations Sector Cure and Shelter Branch activates and coordinates the evacuation shelters. And fortunately, as I mentioned, across the desk is the EOC Operations Section Health and EMS branches, and they support shelter and temporary evacuation points, health services in coordination with Ops and Care and Shelter Branch, and with the DHS DOC. Then, everybody on the phone is familiar with I'm sure with the idea that the fact that we have a DHS DOC. There is also we are responsible there for public health, environmental health guidance, access to shelter, medical and behavioral services, and then really the coordination of all those on the ground resources. And then Human Services has a corresponding DOC, and Human Resources has the primary responsibility for managing county evacuation shelters and temporary evacuation points. At each shelter, there is a shelter manager. I was very pleased to be involved in a training earlier this week that included the DHS shelter managers and other DHS disaster workers, and they really have excellent training. They again, DHS coordinates this. They train the managers. Their training is based on the training for shelter managers that American Red Cross does, but adapted to county shelters. And they really are doing a fantastic job of additional training. Not only do they have this functional assessment services team, a FAST team, they also are training all their managers in how to be particularly focused on issues for individuals with functional and access needs. So those shelter managers, those individuals that, at the shelters and their staff are responsible for the shelter administration, supervision, really identifying and satisfying the needs and safety for shelter residents and shelter workers. So any of you who are in a shelter, they are also watching out for your safety. And we're doing a lot of work with Human Services to make sure we are coordinated in the work that we're doing together. There we go. This slide is actually came from the Human Services training. It talks about decision-making hierarchy and looking at the Department of Emergency Management. This would be the EOC, as you see the different sections, care and shelter, and right next to that would be, as I mentioned, the health section and the EMS section. The main reason I'm showing this is that when we think of it, you know, during a disaster, we are using incident command structure which is hierarchical, but it's important to remember it's a bi-directional hierarchy. We always think of, you know, the direction coming from the top down, but it is equally as important to have information going up from on the ground up to the EOC, because that information is critical to their appropriate management of an incident. So not only is the direction flows down, but information must flow up. If we don't have both, we cannot be successful in managing an incident. So this is the field operations guide that I was mentioning. As I said, this has been updated. We actually started in 2017. We had some things done before, but really 2017 propelled us to develop more and to continue to improve it. This, if you look at the very bottom, that is the DHS Evacuation Shelter Health Services Field Ops Guide. It sits within the Health Services Department, excuse me, the Human Services Department Evacuation Shelter Field Guide. Then that is in turn is part of the Mass Care and Shelter Annex, which is an annex to the Sonoma County Emergency Operational Area Emergency Operations Plan. So really think of it, there's an overall plan, which is the EOP. Within it, every EOP has a Mass and Care Shelter Annex. And then within that, we focus on the shelters. And as an attachment, we've done this field ops guide for the health services within shelters. So I like to quote this Dwight Eisenhower, Dwight Eisenhower said. Of course, he was involved in some of the most complex planning there's ever been for World War II. But he said, plans are useless, but planning is everything. It overstates the case, as do all good sayings. And it means that the plan is very, you know, you need a plan, but it's really the planning, the developing that muscle, developing those relationships is the most important part of developing a plan. The fact that we're having these meetings with our community partners, with the Department of Emergency Management, with Human Services, we are working on very complex issues and working through those. And the incident command structure also gives us that planning infrastructure. And that is really key. But it is not to take away from the importance of the plan, but really our ability to plan is so important. I think we have tremendously strengthened that over the course of the last few years. So again, this is the plan, and you will see it has to do with medical, behavioral health, public health, and environmental health. So we'll go through the different parts of this plan and let you know what the functions are for each of you, you know, each of the sections that you are part of, what the role is. So for public health, just is absolutely critical, always critical, but boy, in a pandemic, it's essential. It's just touches every aspect of planning and responding to a disaster in the midst of a pandemic. So as the public health officer just recently did, the public health officer will issue the orders and guidance to prevent spread of COVID and other communicable diseases, but this is in the general community and within shelters. Really important in addition to this is coordinating and aligning the communicable disease screening, triage, management, disease outbreak investigations across all shelters and TEPs across the county in accordance with those orders and guidance. Also, ongoing communicable disease surveillance, doing disease outbreak investigations, oversight for isolation and infection control. And this is all done in coordination with the shelter medical services team and environmental health. As always, population health assessment, both of the health and medical needs, is an important part of public health. And then one area that has always been important, but I think we are focused more on it at this point, is health equity monitoring. In a disaster, the disaster does not affect every member of the community equally. It has a disproportionate and disproportionately negative impact on individuals who are low income, communities of color, individuals with disabilities, a series of communities that are more vulnerable to the multiple impacts of disasters. So public health monitors that. We've seen it with during the COVID-19 pandemic, that this health equity monitoring has been very important. And then really important, public health also provides technical assistance to EOC operations care and shelter branch. And the example I have seen in every single fire is, as a disaster is kind of getting under control, individuals sheltered or finding other options for sheltering, for going home or going with families or whatever it is. We end up consolidating shelters, and population from one shelter are brought over to another one. And public health is always paying a lot of attention to make sure that at no point are you combining two shelters where one, we have norovirus cases or suspected norovirus cases with a shelter that does not have that problem, because we know that could be really result in other the individuals in both shelters ending up with a outbreak of norovirus. So I want to go over these strategies. At the top of everybody's mind, I think, is how do we prevent COVID-19 transmission among the evacuees in shelters? And, with public health, it's never a single strategy. I really like this Swiss cheese analogy that's presented here. It really talks about, this is the idea that if you kind of cut up Swiss cheese in slices or layers, it is very similar to the approach we have to putting in place multiple layered strategies to prevent transmission. So if you look on the left-hand side of this slide, those are the virus. That's the virus particles going, and then these layers are all our different strategies, prevention strategies. And on the right-hand side, we have that person that we are trying to assure does not get infected with COVID. So there is every single layer of prevention that you put in there does have a hole. But if we line up these layers, if it makes it through one hole, it probably won't make it through another hole. And if we do that over many, it's an additive, even synergistic way of doing it. You really decrease the possibilities of transmission. And this is what we do in the shelter. So here are the kind of the Swiss cheese layer, the layered strategies to prevent COVID-19 transmission in our shelters. First and foremost, and I really want to acknowledge everybody on, who's on this training. You've been so important in the fact that we have high community rates of COVID-19 vaccination. That is the biggest thing we can do to prevent COVID transmission in our community and in our evacuation shelters. So, in Sonoma County, we have over 70% of immunization, COVID-19 immunization rates, with the partially and fully vaccinated, and that is tremendous. If we were trying to set up evacuation shelters, congregate settings, In a community that did not have this, as we were last year, it is much higher. The risk is just so incredibly much higher. So that's really important to remember. In addition, we need to screen everybody who goes into a shelter. So starting with the residents, we do the screening at those temporary evacuation points and at the shelters for COVID-19. We'll talk, this is specific to COVID-19. We'll do some other types of screening, but at COVID-19 screening. Then we triage evacuees based on that screening to where they should be appropriately sheltered. So anybody who on screening is determined to either to likely have COVID, to be a contact to COVID, cannot go into that shelter. They will be taken to the alternate care site, which fortunately is available. And we are looking to expand our alternate care sites in the case of a disaster. And this is really important. They would be put in isolation or in quarantine, depending on that screening. Then we do COVID-19 screening, and this is recently with the health officer order. Anybody all workers in the evacuation shelters must have COVID screening and proof of COVID-19 vaccination or COVID-19 recent testing in order to be able to enter and work in the shelter. And then in addition, we do daily COVID screening of all shelter residents. And if there's any chance somebody has COVID, they're appropriately isolated or quarantined. And we do try to do that as expeditiously as possible to make sure we don't have further transmission. And then addition, masks for all residents. Anybody in the shelter must wear a mask, and that's even when you're sleeping. Anytime when you're not actively eating, you need to have a mask on. For workers in shelters, it has to be a surgical or N95 mask. Social distancing, we know the importance of that. It is absolutely critical. And then we will continue to set up cots with a 110 square feet per resident, which is more than you would normally do. This is something that started with the COVID-19 pandemic, and we will continue to do it. And the head-to-toe configuration, so you don't have two people's heads in close proximity. Frequent hand cleaning, frequent cleaning of surfaces and objects. And then in food service, a lot of you have been involved in disaster response know that, it used to be set up a buffet. We don't do buffets anymore. Not a good idea in a pandemic. And so we're doing single-use packaging of food to again prevent transmission as part of our layered strategy for COVID-19 to prevent the spread of COVID-19. So this is a draft, and we actually had a meeting right before this one where we will have a much more complete screening. But just to give you a general idea, evacuated person presents to a TEP or shelter. They will get a symptom screen, they will get contact questions, and they will have their temperature checked. If they are if the questions are positive, and there's a little secondary screening that goes on after this initial one. If they've had contact or if they have a fever, they will be going to the ACS either for quarantine or isolation. If they have negative questions, negative screening, and no fever, then they will be directed to the congregate shelter with other presumed COVID-19 negative individuals. And then, of course, as I said, we'll be doing daily screening, and this is not a one-time screen. There are a huge difference this year in our ability to send people to the best, to have multiple options for sheltering people, and particularly higher risk people, is the fact that we will not have the non-congregate settings. You remember we had Sonoma State, we had the camps, we had several options. Those are not available this year, in part because of the vaccination rates are so high. We have places are open again, hotels and camps and everything. So we simply don't have those areas. Also, some of the funding that existed for non-congregate sheltering is no longer exists. There is a very small amount of funding, and a small number of individuals are being pre-identified by Human Services for specific conditions that they have. And we're looking at also at some of the conditions that are very similar to those that are how we can make sure people who have very impaired immunity, such as those who have been identified for vaccine booster in the near future, that also we have some additional protection for those individuals, but we are working through that now. So that gives you a sense of public health. In terms of environmental health, it's just essential. And I really want to congratulate environmental health. They've done incredible work with human services. They've been involved in meetings with City of Santa Rosa to really make sure that they are doing proactive work with these other entities that will have shelters, and with the folks who will be running the shelters, so they know they can do as much up front before the shelters open, and then really establish the relationships to facilitate the very important inspections they do. They do initial periodic inspections of all the activated shelters. They respond to reports of when there are unhealthy conditions, and that regards food handling facilities, the procedures, all the food handling in the shelter, potable water, waste disposals, facilities, procedures, pest control, service animal issues. And in some of the shelters, it's pets too, as we have expanded the ability to house people with their pets. And then they monitor these conditions. In our daily meetings, the environmental health report is essential to keeping track of what's going on, where there might be risks, where we need to respond. And then they also are doing population level assessment of health needs. Behavioral health services are important for all of us at all times, but during a disaster it is very stressful. It is very disruptive. County behavioral health provides such important services to individuals with serious persistent mental illness. Those individuals assuring that they can find sheltering, that they have access to their medications, that they are able to be appropriately sheltered. And then everybody who is sent to a shelter, who not sent to a shelter, but goes to a shelter, is in a state of stress. And so having these behavioral health services are so important. So they do observation assessment of arriving residents. They do walk around observations of the shelter residents to determine when there's signs of mental and emotional distress. There are actually some screening mental health questions and health questions that are part of the registration process for shelters. And if somebody registering detects something, they can alert either behavioral or medical health services. They're able to do behavioral health assessments for shelter residents and staff. They refer for additional behavioral health if it's not available at the shelter. And then, as I mentioned before, it's really important, their coordination and transportation of individuals who need a higher level of behavioral health care. And then also substance use disorder, not interrupting that treatment is critical for people who are on methadone, who may be on buprenorphine for doing medication-assisted treatment. Also very, very important. And they coordinate with all our local pharmacies and with county behavioral health to make sure people have appropriate access to their psychiatric medications. And again, they look at things from the population level. They also coordinate their important services with services that are being provided primarily through the COAD. COAD is the community organizations active in disasters. They bring together multiple organizations, and those organizations within COAD who are focused on emotional health and focused on spiritual health have provided very valuable services in shelter, and they coordinate these with shelter behavioral health services. So medical services, this is always a big question. Often when people think about health, they think exclusively about medical, and it's important we think of all the other aspects, but medical is very important to people in shelters. We know in 2017, as I said, it was really a heroic response. Just our community came together, our healthcare community came together, but we had challenges. And one of the biggest was there wasn't a clear definition of the scope of care that would be provided in medical shelters. People did their best, made assumptions about what care should be provided. We didn't have, smooth processes for resource requests, and I'm understating that, and a lot of issues. So we really got together with everybody who had participated over the last 4 years and took their recommendations for improvement. And one of those was really clarifying our scope of medical care. So this is the scope. Level 1 care, medical care, is basic screening, treatment of minor injuries, illnesses, kind of think first aid plus, and that is sort of what you would expect to have at a Red Cross shelter. Level 2 care, we realized we tried to limit, we thought we could, that it would be sufficient to have that, but we found we really do need to also provide access to urgent care for injuries and acute and chronic illnesses. So urgent care is actually defined, and I got out Merriam-Webster's dictionary for this, but it makes perfect sense. Urgent care is that care that you need urgently, but it's not of the level that you would need to go to an emergency department or a hospital for. So we found several ways to provide that over the years in shelters, and we'll talk a little bit about how we envision that occurring. Pharmaceutical management is essential. A lot of that has to do with refills. And just to making sure people have their needed necessary medications. And then another important part of care is this sort of monitoring and surveillance to make sure there are people in that shelter who really need a higher level of care, who cannot remain safely in the shelter because of the level of their medical needs. And so we are part of it is identifying those individuals, and then with EMS and other partners, making sure that they are safely transported to available resources, either locally or out of county. And then always the 911 system. Anybody in a shelter or anywhere else who sees somebody with a life-threatening condition, you notify 911. So that being said, we know there will be times, and we've seen this in almost every one of the recent disasters, when we may need to surge up to a higher level of care in a shelter, but this should be the exception. We call this level 3 and the care, and that would be what care that you would normally get at an emergency department, a hospital, or a skilled nursing facility. And there are a lot of factors that can influence whether we need to flex up or surge up to that level. How quickly a disaster occurs and how quickly the evacuations occur. We certainly saw that in the Tubbs fire, where it was just incredibly rapid onset. The impact of the disaster on the volume and severity of injuries and illnesses. That I always think of the situation with an earthquake. If we have a lot of very sick people, we have to quickly find places for them to receive the care, and our hospitals would be overwhelmed. Impact of the disaster on the health care delivery infrastructure. Again, if you think of this happens during most disasters, there's an influx of patients, but really when you think of this, think more of if there were an earthquake and all of our major hospitals are on the Rogers Creek Fault, so that we could definitely end up with the actual physical infrastructure being impacted. And then the impact of disasters on our community infrastructure, roads and buildings. If the Highway 101 is interrupted, if there's a huge gap in Highway 101 with an earthquake, we may have to deal with a lot of things in county that we would normally and not have the level of mutual aid that we would otherwise. And then very importantly, what is the underlying medical fragility of the sheltered population? And we know we live in a county with an older population. People retire here. We have a lot of assisted living. So we do have a population where we would tend to have higher acuity individuals coming that might require that we have them provide additional care. But this should always be temporary. And what will happen in this situation, it won't just be a local decision, we're moving up to a higher level. It'll be something with the communication systems we have to make sure that EOC basically says, we're authorized as we go into level 3 in this place or this place, and this will not delay that decision making or the provision of care. We're really focused on it not delaying that, and it will contact with our. You'll see we're going to talk. An RFP is going out for a medical services organization. They will be coordinated. We'll be coordinating with them, our local healthcare partners, and all of our regional and state partners too, because we have to make sure that even though we will be flexing up, that care has to be within the capabilities of providers, the supplies we have available, equipment. And then we have to assure that people who do require level 3 care, we get them transported to the appropriate level just as soon as possible. So from the beginning, we have to do, even before that, we will be looking at how we can get people to the right level of care and return to the scope of care that we have identified for shelters to this level of care. So the other thing we've definitely found, and we had the opportunity to test this in 2020, is that medical services are ideally provided by organizations and individuals who have experience, who have expertise with disaster and shelter medicine. And I mentioned the county contracted with DEMA last year, and they, through the multiple disasters in Sonoma County, have a great deal of experience and expertise in disaster and shelter medicine. So it really showed us how effective such a model could be. And this is at the same time that we know that given the frequency of these disasters and given the complexity of trying to provide care during a pandemic, the old model of depending on volunteers to provide medical services is just not adequate to meet the dimensions of the need that we have and the frequency of those disasters. So DHS is going to be issuing an RFP for a qualified shelter medical services organization that would provide care in county evacuation shelters. Now, the care that will be provided, and this is laid out in this RFP also, we've come up with a hub and spoke model for provision of care. And this is actually was implemented de facto in a couple of in several areas in the last couple of wildfire disasters. It is a centralized medical direction and coordination and administration of the shelter medical services. So the contracted entity would provide this centralized medical direction, physician-based medical direction. That contracted entity would report directly to the EOC Ops and Care Shelter in the medical and EMS branches with the assistance of obviously DHS DOC. And we would identify basically 2 shelters initially, and this of course always is going to depend on how large the disaster is, but it's a flexible model. So say it were a very large disaster, 2 hub shelters, and there we would really do, in addition to that COVID screening when people are at the TEP or the shelter, we would also screen for their medical conditions. This is not a detailed intake at a doctor's office. This is really, are these individuals who have have a level of medical fragility that they really need some enhanced monitoring in a shelter. And if we identify folks like that, we want them, and they of course can bring their families to one of these medical hub shelters. They won't be the only ones in that medical hub shelters, but it'll just be the medical services in that shelter will have a more complete team in terms of the staffing, but not more complete, a little higher skill set in terms of medical skills, and be able to do this monitoring. Sometimes folks are put into kind of a specific area of the shelter to allow staff to keep a closer eye on them, to assist them with, tasks that they're having difficulty with. But this is this nursing and sufficient physician staff backup 24/7. Doesn't and sometimes that's offsite, but basically somebody is there, and then there's physician backup for that. The other shelters, the majority of shelters would be basic hub, basic scope. I'm going to do that again, would be spoke medical services shelters. So these are, again, just regular shelters, but the level of medical services there would be more of that level 1 with access to the urgent care that may be on site or may not be on site. But this is kind of what you would think of a general population shelter with the basic medical services. And they will be linked in. Again, the advantage is this, it's really, think of it as a system where the care is provided out in the different shelters, but you can rely on this centralized medical entity that will be coordinating all of it. So what are the advantages? Well, greater consistency, coordination, integration of the medical services, both within a specific shelter and across shelters. Clear chain of communication and coordination with DHS and EOC. And if you're, I always think resource requests. We know that this is always such a challenge. This clear chain of communication and coordination, that's one example of an area that will tremendously benefit from this. Centralized command and control structure for medical services within and across shelters, so you get that medical direction, operations management, and administration support. Standardized operating procedures, workflows, documentation, and really importantly, centralized recruitment, credentialing, coordination of staffing and scheduling, and the supervision of staff. That's been a real challenge across disasters, and having this possibility is just essential to the safety and the smooth functioning of medical care in the shelters. We are expanding telemedicine capacity, and that will in turn expand access to care for evacuees in shelters. And we've seen a tremendous increase in the use of telemedicine through the COVID pandemic, and we really want to take advantage of that greater comfort and access to telehealth to use it successfully within shelters. Finally, this hub and spoke model also links in with behavioral health, public health, and environmental health, as well as the functional assessment services team, the FAST team, so that we really can coordinate care for individual shelter residents and for the resident population, the shelter population as a whole. And it's interesting, I've been using the term shelter residents, but Human Services refers to shelter guests. And I think it's a great way to think of individuals, evacuees in our shelters. So that is a pretty quick overview of the planning process we've been doing, the document that has been developed, and most important, going back to that Eisenhower quote, the real planning infrastructure and muscle that is being developed across Department of Health Services. And now I'm looking forward to hearing your questions. Dr. Baldwin is here, Andrea is here, and Cynthia, I think, is going to facilitate the questions, but please don't hesitate. And then if you have any technical issues, Linda can help with that also. So I will turn it over to Cynthia at this point.
So thank you for joining us on a Friday afternoon. We have 3 questions so far. The first question is, will daily testing for shelter workers, will there be daily testing for shelter workers who refuse to be vaccinated?
We're going to be following the health officer order. And what that is for unvaccinated shelter worker staff, they need to get tested, provide a negative COVID test weekly. And we just had this conversation with our shelter planning team. Before starting work at the shelter, we would want to confirm that they've had a negative test within the week, that week. So the orders for weekly testing, and we will confirm that they have a negative test prior to starting work at the shelter, if they're unvaccinated.
Thank you, Dr. Baldwin. The next question is, will we receive advance notice for any anticipated DOC assignments?
So this question actually came up yesterday too, and I'll give a little bit of background on the DOC project that Preparedness has been working on. About a month or so ago, the executive team had asked us to take a look at our Department Operations Center roster and see how we might be able to build more depth with it, just because, we've been listening to what people have been saying, in terms of all the after action reviews, that, we rely on too few staffing, that it's usually the same staff that are plugged into the different DOC positions, leading to a lot of burnout, understandably. So one of the projects we've been working on then is to try to build out the DOC, and we're doing this in collaboration with HR, and looking at having 6 different teams within that roster, filling all the different command and general staff positions that make up the DOC. And then in addition to that, having teams of field staff, it's usually environmental health, behavioral health, public health, and of course others across the department who are deployed to the field sometimes to assist in these situations with assessments or providing support in the shelters. So we also are looking at building out those teams as well, once again, so that we have more depth and breadth to those teams. So along with that, we've been looking at Department of Emergency Management has an alerting system in place that they use actually either to the public, but also to alert people to come to their emergency operations center. And Cynthia and I had a little bit of a training on that system a month or so ago, and it looks like something that we can potentially use. And DEM, is offering for us to use that system free of charge even. So once we have the teams built out, the idea is that we'll put the teams into that alerting system and then, notify people in multiple ways. You can choose the way you want to be notified, whether it's by phone, text, email. There will be a way to select how you wish to be notified. So, all those things are underway. Of course, it's not going to be done immediately, though we would like it to be, but, to be continued, and you'll definitely be hearing more from us, regarding our new DOC build out and what that means for everyone who will be working in the DOC.
Thanks, Andrea. The next question is, how long do you plan to use volunteer medical help prior to contracted medical group taking over? 24 hours, 48, or 72?
I'm going to try to, I'm not sure I'm answering your question, but I'm not sure I totally understand it either. So this is how it's currently, I'll just use last season as an example. We worked with a medical provider group who we don't technically have a contract with, but they provided the services, and we, filled out a, MOU with them, and we did pay them for their services. So they weren't volunteering per se. They worked with us and worked at the shelters. They did a fabulous job. And during the whole disaster, we're working on the, MOU and getting them paid as we go. So, but the idea now is we want to put out a request for proposals to everyone in the county, and any medical providers or services or groups that want to provide disaster shelter medical service for us. And so then they will be under contract, and they would be our contracted medical service provider moving forward. So I'm not sure if that answered your question. We are not currently under contract with anybody to provide services, medical services at our shelters. We have a group who has been very gracious over the last couple of years who have provided that service, and we do pay them for that service, but we do not have a contract with them that's binding for, X amount of time or anything like that. But that's what we're working on. We'd like to have somebody dedicated that we always know this is our group we can call on. If I didn't answer your question, please let us know in the Q&A or the chat, and I'll try to.
I think you did, Dr. Baldwin.
Okay.
They were basically asking how long will we use volunteers prior to the medical group, assuming that we would use volunteers first. I mean, you've outlined that we would be using either whatever group responds to the RFP, contracted medical provider, or hopefully a gracious provider like DEMA or some other agency that has that expertise.
And to go back to the volunteer thing, I mean, we can maybe incorporate, I think we hope to incorporate volunteers into the medical service that we provide at the shelters, but they would still fall under the medical service provider who we end up with a contract with. I mean, they wouldn't have to hold that down the fort before they start. It'd just be incorporated into whatever needs need to be met that the service provider identifies. About as clear as mud, I think, how I explain that. So
Their combined effort, I think.
Yes.
Okay. Yeah. The next question is, what is the public health nurse role in the shelter, and how will we be notified for shelter work?
So it's a good question. Regardless of if you work in disease control, you've been asked to participate in training because as a public health nurse, you may be asked to help out in the shelters. We're kind of still fine-tuning and working out what exactly that role will be, because last year we didn't use any public health nurses at all in our shelters. And everything ran pretty smoothly, but I don't think we can rely on that all the time. Environmental health really did a fantastic job of picking up a lot of that that slack, because our public health nurses were really, neck deep in COVID and just trying to maintain the programs that we have at public health or human services. So we really leaned heavily on environmental health to, check the facilities and make sure that the beds were, the right spacing. And again, they were following up on the food and the temperature of the food to make sure that, we weren't getting set up for some sort of infectious disease like norovirus, which would just be a disaster. And they were, they'd actually, kind of go around and check other infection prevention things that we identified as being important in the shelter. So they've helped quite a bit. And again, luckily our medical service providers for the last couple of years who have helped us out, they're fairly well versed in a lot of this as well. So they were also making sure everyone was wearing their masks and things like that. So I can see the public health nurses being weaved in as a help with any kind of infection prevention, needs at the shelters. Potentially, being helping out putting Band-Aids on knees or something like that. But we haven't totally, I think, flushed that out and how many we would need. And so I think Dr. Maddox-Gonzalez, please chime in. It looks like you want to say something, and then we can also follow up later.
No, I think you said it very well. Public health nurses have always been such an important part of the supporting the shelter. But last year we did have to change the model, as you were saying, because of COVID and the need for nurses to be appropriately focusing on that and maintaining the programs. So we did shift and kind of asked environmental health to do some of the things that we traditionally have had the PHNs doing, and then asking the medical provider, and it's sort of shifted that way. But remember, there's with disasters, we never know. We try to plan as well as possible and ability to surge up, but there is always the possibility. I mean, it's terrible. Never say things couldn't get worse, and sometimes that happens in disasters. So there may be times when you will be called upon, but it is not the model. I saw Nancy mention in 2017, we've moved away from the model we had in 2017 to close to this other model where we're distributing some of those communicable disease and other tasks in the shelters to others. But your expertise will still be central to, relying on that for control of outbreaks and all, but less boots on the ground in the shelters.
And I think it also, I think Dr. Maddox-Gonzalez also mentioned earlier, we don't know exactly how each disaster is going to play out. Maybe our medical service provider can provide, X number, but we need to supplement them and help them out in the shelters. Or maybe environmental health is totally overtaxed with what's happening in the environment. I mean, it's an actual disaster happening as well. And they've got other duties that are related to, say, a wildfire or flood and things like that. So they may not be able to do that same level of checking for disease prevention or mitigation measures that we want in place. And so we may call upon our, PHNs to help out with things like that. But that's not our primary plan. That's not, I think, plan A.
Excuse me.
Thanks, Dr. Warren. The following question, will MRC volunteers function under the oversight of the contracted medical group or direct county oversight? There's a second part to the question. And who will call in MRC volunteers and make decisions about where they will be deployed? I could read the second part again if you didn't get it all. Okay.
I can start with the first because I think Andrea and the public health preparedness team probably have a better sense of how we're calling in the MRC volunteers. But yes, we would like them to fall under the umbrella of whoever is the designated medical service provider. Again, we want this centralized operations. So we're not sending our MRC volunteers out to do one thing, and maybe the medical provider doesn't really know that that's what they're doing or doesn't think that that needs to be done. It's gonna be a collaboration, but In general, we want the volunteers to fall under the direction of the medical service provider. But this is what I'm assuming is going to happen. And you know what they say about making assumptions, but we've had a really great relationship with the medical providers for the last couple of years, and it's really a back and forth. Where do you need help? Okay, we can help you. We can probably call in some of our MRC, volunteers, and so okay, this is where we need them to go. And all right, they'll report to you at one place, and you can tell them exactly, which shelter you need help at or something like that. But we really do want a centralized system, so you're not, reporting to 5 different groups or people. Make it clear and streamlined.
The other thing that we're looking at too is, we mentioned these temporary evacuation points, and with the screening that will occur, there might be a role for the MRC in that capacity. But again, we want to link it back to that centralized structure so that we can really coordinate all of this work and make it work as smoothly as possible.
And the notification of the MRC will work the same way that it does now. You'll be contacted by preparedness, Claire and Greg, essentially, and, they'll let you know what type of assignment, we're looking to be filled, and we'll be communicating with the, contractor on that, and then, get volunteers the same way that we've been doing all along.
The final question in Q&A, and then I'll move into the chat, is when will the rosters of teams be finalized?
Good question. I know that Andrea and Cynthia and the team are working on that now, and I believe there'll be some, it needs to keep working its way on up through DHS to get the final approval. But Andrea, you probably have some more details than I do.
Yeah, I think we're getting there. I think we're almost done. I mean, the DOC roster, the 6 teams have been built out, and now, we're consulting with behavioral health, environmental health, and public health to figure out the field teams. So once that's done, then it'll be presented to the exec team for approval, and then hopefully we can formalize it afterwards. I should say we are planning on starting again too the DOC quarterly drills, which I think used to happen previously. So that will be an opportunity too to do some training, have people participate in exercises and start learning their roles if they're new to the whole incident command system. And we hope to have our first DOC drill, and it'll probably be with maybe one initial team to start with. We haven't quite figured out how we're going to structure it yet, but we're looking at potentially the end of September.
The first question in the chat, and Andrea, you addressed it somewhat, is I am an RN or public health nurse embedded in the HSD. DHS has not trained me or made clear my role since I served in the 2017 vet building medical shelter. Can I serve or may I serve with HSD if DHS has no plan to utilize me?
Yes, I mean, there will be additional training opportunities available. And also, there are trainings that happen at the regional level, at the state level, that we can point people in the direction of, as well as including a lot of different online trainings too. Of course, my opinion, I think the most useful type of training is the drills and exercises that I was talking about previously, as well as, getting involved in some actual, activations for some different events is a good way to get trained as well. I don't know, Mary or Dr. Baldwin, if you have anything else regarding that.
I don't have anything else, but to your question of whether or not you could, if public health or DHS isn't utilizing your services, can you help out with human services? That's a good question. I don't know how that works. I'm not sure. We could probably ask, I don't know if it's HR or Tina, I'm not sure. I'm not sure the answer to that, but that's one we can take back and ask. And I don't know if, I think last presentation or training, we got a list of the questions and maybe who asked them, because this is one we'll have to, I think, follow up with you on.
Next part of that question, and I'm assuming, is if they're deployed to a shelter in the event of a disaster, who will be their point of contact, and will there be an org chart available?
We'll follow the ICS system. And so, essentially that's following kind of the standard org chart for ICS. Of course, will always be changed a little bit, depending on the type of disaster, not always going to be activating, all the same individuals for a disease outbreak that you would, for a wildfire response. So really the structure, is highly dependent on the type of disaster. But it will always, follow the general ICS, command and general staff structure, which is, the incident commander or DOC director, depending, you can called either one, and the support team that goes along with that. That includes the public information officer, the safety officer, typically a liaison officer, and then you've got the different sections: operations section, finance and administration, planning, and logistics, really important one. So it will typically follow that structure, and you'll be reporting according to that structure.
The next one, and I'm not sure if it's a question or statement, but it's from environmental health. And they said specifically, they noticed during the previous disaster that some of the tasks that they were assigned did not need a high level of specialization, and that they're a small group, and it would be helpful if other departments could be called on to help. And they wanted to know who is going to be responsible to make sure that responders have adequate and sufficient PPE.
I'm sorry, I was trying to unmute there. I mean, we're working with environmental health very closely. So if they identify that they don't have the staff to help support other functions that could be done by other people, then that's a potential of not having to participate in the shelter work. But that's a one-on-one conversation, I think, about the situation at that time. I don't think we can make a blanket statement that if others can do it, we're not going to, use environmental health, utilize staff from environmental health for shelter duties. So I think that would be more of a conversation with Christine or Leslie at the time, based on the situation that's happening. Because I have to say, I think I could say the same about many of the other programs and services. There's not enough staff it's very difficult to maintain the continuity of operations if when staff go out. But that's what we're asking of everybody, is that what's your minimum level of continuity while we're in a disaster, to keep the shelters going and our everyday programs and services continuing as well. And those are hard decisions, but that's not the best answer, but that's kind of where we're at. I think that's on a situational basis.
The final question in the chat, and it's from Human Services, HSD, and they mentioned that, actually there's an additional one. But on that one, they mentioned that if they're going to be sent to a shelter, they need some basic training, and that it's difficult to be thrown into a shelter work with no basic training.
I wanted to mention something, Nancy, because I think this is a really important area to clarify. You mentioned Human Services. They do have some wonderful shelter modules, and they are responsible for everything in the shelter. I mean, they have to get prepared for it. They have to deploy the equipment. They have to set up each and every one of those cots. They have to be the management, all of that. And they really have done a phenomenal job of that. Health Services has a very specific role within shelters. And it's really important, but it is a limited role within there. So that's one thing that just to be aware of, because I know I've gotten some questions sometimes about things that, and I'll say, actually, we have no authority over that. That's Human Services that are the ones that have to make, or Department of Emergency Management. And they have a level of training that is really important to be able to manage 24/7, day in and day out these shelters. With health, what we've seen is that, when we did 2017, we figured we needed doctors and nurses, 24/7 to do the work there. And the model that has evolved is much less reliant on doctors, much less reliant on nurses. They're almost more in a support role. We're seeing more EMTs, nursing assistants, a lot of the care with that, even the team model. It's more of a team model as opposed to individual doctors, individual nurses going out and providing the care. So I think that's part of it too. What I'm getting to with that is that it's much less likely that you will be asked to go and have a frontline medical role in a shelter as a nurse, because of the shift in this model. But also the type of training, I really applaud the training that they're doing in Human Services, but it has to be a more complex training and greater depth because of the level of their responsibility. But I just wanted to bring that up. But you're absolutely right. We've all ended up in a shelter without any training, and it's not fun. So we are trying, that is part of what we're trying to do with this and build upon it. So and your question and others are really helping for that. So thank you.
The next part of the chat, and I was in this situation last year, says, how are you planning for staff who are scheduled to be deployed or evacuated themselves, or whose children's schools, daycares are closed or evacuated and don't have daycare?
I can start, but Andrea, please finish. I think that's why we have the 6, groups, and maybe you can't do it this time, but the expectation would be, maybe the next time. And so we'd like to, again, we need some depth. It can't always be the people who, unfortunately, it can't always be the same people who may not have children or may not have daycare issues or may not, be in a high evacuation area where they get evacuated frequently. But that's why there's flexibility with the 6 teams, so that if you are that person who, doesn't feel like they can report this time, you'll be the next time. Maybe you'll be in the next group that goes or something like that. But Andrea, please clarify or add on.
Yeah, no, that, was kind of the purpose of having those 6 different teams, so that, if someone wasn't available, we would have some backups. And in addition to that, there's some roles within the DOC that definitely can be virtual. So, you could support from afar, although I know being evacuated is a stressful situation and it may be difficult to work. But, in some circumstances where you're still able to, for some of the positions, I'm thinking of the planning section in particular, if you're working on a lot of documents, writing up the IAP, those are definitely things that could be done remotely, and having a partial virtual doc could definitely support that, I think.
And the next question, you kind of spoke to it as well, Andrea, where they're talking about, you talked about having the team so we have a level of redundancy, and also to address some of the concerns that came out of feedback that we received, making sure that there's not a high level of burnout, but that we can sort of spread the load and everyone could be given reasonable amounts of times or shifts so that there's not complete burnout and we can provide the level we need proficiently.
Yeah, we definitely want to avoid people, being stuck in 12-hour shifts or, longer than that for weeks and weeks at a time. That's just not something that's very sustainable and will cause people to not be interested in, being a part of the DOC. So, hopefully having more people trained and plugged into these positions will address some of that.
I'm going to go back. I remember there was a prior question and basically asked who was going to be providing PPE equipment for volunteers or for those who have to be deployed at shelters.
We have PPE for staff that are working in the shelters? I guess that's a short answer. We have PPE, I think in our warehouse, and it's available for people working in the shelters. But Andrea, looks like you want to say something.
Yeah, definitely. Now we have a plethora of PPE, in our RSS warehouse, and then also we've got some in our preparedness warehouse as well for these types of situations.
There's a final comment in the Q&A. Let me get there quickly. I hope you're not going to undervalue what the Red Cross calls cot-to-cot nursing assessment by not encouraging or supporting nursing personnel on the ground and in congregate shelters. Proactively making rounds as opposed to waiting for guests to ask for help really minimizes problems and keep them better managed.
We agree. And our medical providers last year, that's exactly what they did. They had shifts, and every so often they were going around to all of the cots or in the rooms, because some of the shelters had different rooms, and they were doing exactly that. They were going around and just asking, does anyone need anything, or looking at people, trying to make assessments. So we totally agree.
If there are no other questions, thank you for participating this afternoon. I can wait a while in case there's any other questions, but otherwise, everyone can have a great weekend. Doesn't look like any other questions, folks.
Thank you.
All righty, thanks.
Thanks, everyone.